In this segment, I want to talk specifically about SSRI medications. In the other segments, we'll probably talk in general about medicines you would see in specific illnesses like depression or anxiety or bipolar disorder or autism spectrum or any of the others. But we actually use the SSRI class of medications for so many different things. They have become sort of the Swiss Army knife of medications for psychiatry. And not just psychiatry, they are actually one of the most commonly prescribed medications out there, both by family physicians and internal medicine doctors, and so on and so forth. And that's because they have become quite useful for so many different things without too significant a side effects in most cases. And so they're safe and they're effective. There's some debate as to whether or not they are particularly effective in mild depression or moderate depression, but they certainly are first-line medications for severe depression and anxiety and, as I said, OCD. So we no longer refer to them as antidepressants for that reason. Now, first of all, I want to give you a kind of idea of what the most common ones you might see. And so right now, this is a list of the most common SSRI medications out there. And most practitioners know that medicines have two names. One is the generic name that is given to it, kind of the name that's given to it when it's created in the lab. And the other is the trade name that is patented usually when the medicine is first released. And then once it comes out in a generic form, people refer to it as generic name. But I often have patients ask me, gee, doctor, I thought I was on sertraline. Why do you keep saying Zoloft? Or conversely, why did you say fluoxetine when I'm on Prozac? They're the same thing. One is the generic name and one is the trade name. It's quite interesting because in medical school, when I was going through a few years ago, they basically decided they wanted to be farm-free, which meant they didn't want any trade names used at all. And they were actually telling lecturers not to use trade names, to avoid them. You could get in trouble for actually using a trade name when you were giving a lecture on medications. Unfortunately, this actually has proven to be a bit more confusing sometimes because I have to actually go back and look at what the trade names are sometimes by saying, okay, you're on, let's see, citalopram. Let me look that up. Oh, yeah, that's Celexa. And it really is important to kind of know both names and know that they're one and the same medication. So if what I'll do is up there, the generic name is the one that you see first, and then in the parentheses is the trade name. So one question is, how do these medications work? And I won't go into a lot of detail, but everybody's probably heard of dopamine or serotonin. These are important chemicals in the brain. We call them neurotransmitters. And this is why they're so important. The way the brain works is if you take two neurons, which are the nerve cells, and there are, of course, billions of neurons in your brain, but there's actually trillions of synapses. And I'm going to explain what that is. There's more synapses in your brain than there are stars in our galaxy. I think that's a fascinating statistic right there. But what they are is your brain consists of billions of nerve cells, but they don't actually touch each other. They actually have these things called dendrites, which are like little arms that come off of, and you may have seen what a neuron looks like, a brain cell. But they have these long arms that come off like this, and they get really close together and they create something called a synapse, which is a space that's between these two cells. And this is important because the way that this cell communicates with this cell, and the brain is just a whole bunch of cells that are wired together, the way these two communicate is across this space. And they do it through chemicals. So if this is the cell that's sending the signal, it releases chemicals into this space called a cleft or called a synapse. This is the receiving cell. It's got a bunch of receptors on it that's able to detect these chemicals when the chemicals are released. And when those chemicals are released, this one says, oh, there's those chemicals, and it sends the signal on. So all of the communication in your brain is done by chemicals across these gaps. And that's where things like dopamine and serotonin and norepinephrine and all of these chemicals come into play. So serotonin is one of the most important, and it really plays a big role in the frontal lobes right here. And this is the executive center of your brain. This is where a lot of the decision-making, the higher order decision-making goes. Should I eat that cake or not? I feel like eating that cake, but I don't think I will. That's all basically done in the frontal lobes. And serotonin is an extremely important chemical in this particular area. It's important for mood, obviously, because we worry about it in depression. It's important for concentration and attention. It's important for pleasure. It's important for sex drive in some ways, which is why some of the side effects of SSRI medications are important. It's also important for moderating pain, and we know that there's a role for the SSRI medications in chronic pain as well. And so serotonin is just a super important chemical. So in a normal cell situation, here's what happens. This is a sending neuron, and it releases serotonin into the synapse. And that stays in there long enough to trigger the cell, sending on the message. The problem is that the brain likes to conserve or keep that serotonin rather than break it down and use it up. So the sending cell has little pumps that as soon as it releases the serotonin out into that synapse, it starts pumping it back into itself so it can be used again later. So the serotonin comes out, gets pumped back into the cell. The problem is that sometimes we need that serotonin to stay in that space longer in order for it to be effective. And that's what selective reuptake inhibitors, SSRI medications, do. They actually inhibit this little pump that's in this cell and allows the serotonin to sit in that space for a longer period of time. And that is all it really does. And that's one of the things I like to tell my patients that, because sometimes it's nice for them to know that the SSRI medications really just help the body do its own thing rather than give it something it doesn't already have. It's just helping the body use its own serotonin a little more effectively. So the other thing to know about SSRI medications is that they can take a while to take effect. And we're talking about 2 weeks to up to 8 weeks. And the reason for that is because it is affecting these pumps. We think it has to do with how these pumps are being built. And so new pumps have to be built while you have the medicine in you to have these like less effective pumps for sucking up serotonin. And that's why it takes time, because the old pumps get replaced, the new pumps get put in place, and the SSRI becomes more and more effective. So one of the things one of the reasons why we have so many different medications are we have so many different people and different liver types and different body types, and each person breaks down the medication differently. So one person, you give them Prozac and they may just get a side effect with no benefit. Another person, you give them Prozac and they don't have any side effects and they have a great response to it. The other problem is that, well, it's just not one size fits all. And SSRI medications are actually considered such a mainstream treatment that if we do have a medication that doesn't work or gives side effects, the next step will be to actually try another SSRI and see if that one works better before we give up on that class of medication. As I mentioned previously, you can't really compare doses either. It's important to know that one dose of, for instance, Lexapro, 5 to 10 milligrams, is a pretty effective dose for people, versus getting into Zoloft, you have to get up to 50 to 100 milligrams, sometimes higher. They just aren't equivalents. So it's important to keep that in mind as well. Now, the other thing that's different about these medications from one to the other is how quickly they disappear from your body. We talked a little bit about half-life before, and it's important to kind of know that. Some medicines, like Prozac, for instance, have very long half-lives. And what that means is you only have to take it once a day. And if you actually miss it from day to day every now and then, it probably won't matter because it stays in the system long enough. Or, for instance, if you take Paxil, which has a very short half-life, if you miss it the next day, you'll often feel pretty bad. And that's one of the reasons why people have an issue with Paxil, is that you could just miss it for one day and you get that discontinuation syndrome. So they're not all alike in that respect either. Now, the other thing that is good to know about these medications is kind of their side effects. Luckily, they're very well tolerated in general. Most people do pretty well. The most common side effect, interestingly, is stomach ache or diarrhea or stomach discomfort. And that's simply because there are about 9 times as many serotonin receptors in the gut, in our intestines, than there are in our brain. And so when you start taking an SSRI, it makes for I like to say it's a happy gut, although that might be not necessarily true if you've got a stomach ache, but it makes for a very active gut. And so that's one of the reasons why that can be a side effect. It takes quite a bit longer for it to get over into the brain area and build up those pumps. Another common side effect is headache. Most of these will go away usually in 3 to 5 days. Sometimes can last as long as 7. Outside of that, if they last longer, I tend to think about changing to a different medication. Also, weight gain is not uncommon. 20% of people on SSRIs will see a little bit of weight gain, so it's worth it to mention that. Not as bad as many of our other medications. And one of the nice things about the SSRI medications is you'll tend to gain some weight but then plateau out. It's like kind of like you just gain a little bit but then stay there. Unlike some of our other medications where it just kind of keeps going up. Sexual side effects can be a reason why people do not want to stay on the medication. It can actually reduce your ability to achieve an orgasm. It can also make it harder or just lower your sex drive in general. So those are reasons we often have to change the medicine. Often, though, just going from one SSRI to another will fix that. So, and it's a very important thing, and we need to make sure people are aware of that beforehand. And of course, the black box warning I talk about in some detail, so I'm not going to go into that right here, but adolescents and young people, there is a black box warning for increased suicidal ideation in that population. It's relatively uncommon, but once again, see my video specifically on the black box warning if you want to have more information and more interest in understanding that particular phenomenon. Finally, I did want to talk a little bit about serotonin syndrome. It's not something that happens very often. It's actually quite uncommon. I have seen serotonin syndrome once in one person who was on one SSRI. It was a young man who came in to see me at the Star Clinic, and he was actually referred by one of the nurses because he'd come in and he was describing his symptoms, and they were like for an intake, and they said, "Would you see this young man and see what you think?" He was in his early 20s. And when he came in, he was really jumpy and jittery and anxious and angry, and his pupils were kind of big. And I went like this, and he jumped, and he said, "Why'd you do that?" and got all upset with me. And this was serotonin syndrome, pretty clearly, and I had him stop the medication, and within a couple of days, he was fine. So still on the depressed side, but Zoloft was not the medication for him. Turns out he was only on 50 milligrams of Zoloft, the starting dose. However, very uncommon. And as a matter of fact, the only times I've ever seen it otherwise is on overdose, when somebody has taken all of their SSRI medication. And we're talking about a lot, way more than they're prescribed. And even then, it's a mild to moderate case. We just have to stop the medication, let it come out of the system, and then start again. It's one of the reasons why we like using this medication in depressed populations, because it's pretty safe even in overdose. The other thing we have to watch for, though, is the mixing of medications. There are some medications that are definitely not good combinations. Other antidepressants can be an issue, especially things like MAOIs, which we'll talk a little bit about that when we talk about depression. They can allow that serotonin to build up way too quickly. Those are the combinations we have to watch for. But just being on an SSRI is generally very safe, and one of the reasons why we prescribe them so much. Another thing that's useful to know is that depression tends to respond to the medicines at lower doses. So a lot of our studies would show that, if you weren't responding to Prozac by 20 to 40 milligrams, you weren't likely to get much benefit by continuing to go up. However, it's turned out that anxiety, and especially OCD, often require higher doses in order to respond. You often see us getting the doses up to 80 or 100 milligrams of Prozac, for instance, is not completely out of the realm of dosing for obsessive compulsive disorder. So it does depend on what we're treating and how we're approaching it. And it turns out we not only use these medications in psychiatry, there may even be a role for some of them outside of that. Luvox, an older SSRI, has shown some benefit in reducing the symptoms of COVID-19. That's very preliminary, but very fascinating. So once again, the Swiss Army knife of medications. We're also using them for pain, and they can be quite effective for some of our chronic pain situations like fibromyalgia. Well, I won't go into any more detail. I hope this is useful. Starting with the next one, we'll start with an actual topic, anxiety. And until then, I just want to remind you, don't believe everything you think.